Good morning, Chair, dear colleagues and seniors. So I am going to present our trial on behalf of the Scotch investigators. So this is a placebo-controlled randomized double-blind trial to evaluate the use of tolvaptan for hyponatremia in cirrhosis. So I bring warm greetings from my institute, and I've been fortunate to work with great colleagues. So end-stage liver disease is marked by significant events which have large bearing on the trajectory of the disease, the morbidity and the mortality, like hepatorenal syndrome, hyponatremia, hepatic encephalopathy, and infections including SBP. So hyponatremia presents a significant clinical quagmire as alluded to by Professor Kamath yesterday. And currently, there are multiple treatment options like solute and water restriction, albumin, stoppage of diuretics, beta blockade, and TIPS and transplant to treat. Currently, the new kids on the block, Vaptans, are there to treat hyponatremia has been increasingly used, but there is significant concerns regarding its safety and efficacy. So Vaptans, as you know, are selective AVP type 2 receptor blockers, which ultimately lead to solute-free diuresis, increasing urinary output, decreasing urinary osmolality, and causing a net increase in serum sodium. So as we know, the prevalence of hyponatremia varies widely based on the cutoffs you use and also on the severity of the liver disease. We know that for every 1 milliequivalent fall of sodium below 130, there is 12% increase in mortality, and hyponatremia causes significant fall in the quality of life, is a significant predictor of hepatic encephalopathy, it precipitates it too, and hyponatremia is associated with increasing death on the transplant wait list. So our clinical question was whether oral tolvaptan can improve cirrhosis-associated hyponatremia versus matched placebo. And our primary aim was to evaluate the ability of tolvaptan to correct hyponatremia in cirrhotic patients. And our composite endpoints were the change in weight loss, the need for paracentesis, the incidence of treatment emergent side effects, and to make a predictive algorithm to see for tolvaptan responsiveness. And based on a previous study by Wong et al., we calculated the sample size to be around 50 in each group. So this was an investigator-initiated, placebo-controlled, randomized, double-blind trial. It was done at Amrita Hospital, which is a quaternary to tertiary center. And all adults above 18 years with a definitive diagnosis of cirrhosis with hyponatremia, we defined hyponatremia as 125 milliequivalents. And these were the standard exclusion criteria as used. I would bring your attention to the creatinine here. The trial was conceived before the ICA consensus statement, so we have used a cutoff of 1.5. And we have excluded people with hepatic encephalopathy more than grade 1 because that may interfere with their thirst mechanisms, so we had to exclude them. So from the period from August 2019 to June 2023, we assessed 2,400 odd patients for eligibility, and we excluded 2,341 patients because of their baseline being more than 125 or improvement in sodium to more than 125 with aggressive medical management. We excluded significant infections, and then people who have received a tolvaptan dose before enrollment was also excluded. So we gave all these patients intensive medical management for the first 48 hours, which included stoppage of beta blockers and diuretics. We did a diagnostic paracentesis and a procalcitonin to rule out sepsis, which could have confounded hyponatremia. And we restricted the input. I would again highlight the fact that we restricted the input to urine output minus 500 only for the first 48 hours. And finally, we randomized 100 patients, 50 into each group of tolvaptan, 15 mg per orally once a day, and which was a placebo, which was a matched, similar-looking cornstarch tablets. And we followed up all of them for all of the outcomes every day for the first 7 days, and then we did periodic analysis at day 28, day 180, and at 1 year. So These were the baseline characteristics. So you can see that these are predominantly males, with etiology being alcoholic liver disease or metabolic dysfunction associated liver disease. And they were matched at baseline for most of the parameters except the serum potassium and the ALT levels, and their renal and baseline hemodynamics were also comparable. A point to note here is that there is significantly non-significant but definite higher level of spot sodium in the tolvaptan group, which we did not have an explanation. So these are the results. So when you come to the day 8 sodium, we see that there was a statistical significant improvement in sodium. It was there in both groups, but the absolute increase was more in the tolvaptan group as expected. And the rate of sodium elevation was also significantly higher in the tolvaptan group. There was no significant other differences except the ALT, but none of which required treatment discontinuation as per our trial protocol. Now, though the trial was not powered for survival, we can see that at 6 weeks there is the turning away of the graph, but that was not statistically significant. When you look at the predictors of day 8 sodium response, we can see that on linear regression, any treatment with tolvaptan, the urinary spot sodium and bilirubin could predict the sodium level on day 8. So adjusting for MELD sodium at baseline, the tolvaptan use was not associated with better survival at 24 weeks. And when you look at the treatment emergent side effects, they were largely comparable, but the only difference being in 10 patients with the tolvaptan group had rapid rise of sodium, but we did not have to interrupt the therapy of more than 8 milliequivalents. So that was the only significantly different side effect compared to the two group. The electrolyte, the other, everything were, all other parameters were comparable. Now, there was no significant change in the bilirubin, the creatinine or the MELD, which was our concern based on the Tempo 3 trial published in 2012, wherein they found that there was discontinuation rate of 23% versus 15% in the placebo because of hepatic adverse events. But as you would have noticed that we have used much lower dose. So this is the literature that currently exists. So the population subgroups are quite heterogeneous. So they've said that there was increased chance of sodium normalization in the tolvaptan or the vaptan groups across all the studies. And some studies reported significant improvement in ascites control, and only one study reported survival improvement. Closer home, we have a study by Professor Virender Singh, my teacher. So in that small pilot study, there was significant urine output and urinary sodium improvements, but again, his group also did not show any ascites improvement. What are the strengths of our study? Largely, it was a double-blind investigator-initiated, and then we could also see that 50% of people with aggressive management would not need tolvaptan, and this addresses the dilemma of liver and renal safety, and the limitations being that we are a single center study, and the referral centers would have different practices which could have affected, and we were not powered for survival. So we are, based on our study, we are doing few other trials on refractory ascites based on our experience gained from this trial. And I would like to place on record my thanks for my collaborators for this trial.
Arun, you said that you gave 500 ml minus the urine output.
Yes, sir.
So if the urine output was 500, you gave them no fluids.
So we have already excluded people who have got urine output less than 700 ml as the exclusion criteria. And so our entry criteria was a urine output more than 700.
Okay, so they gave 200 ml fluid only.
Yes, sir. We did not, only for the first 24 hours, if we found that the patients were, though it was the criteria, the people, as you would see from, I think my slides have been cut off, the most of the people were having an urine output around 900 to 1200 ml.
What was the average duration of tolvaptan treatment?
So we have given only for 7 days, sir.
And you look for survival at 24 weeks?
Yes, sir. We just followed up them. That was not the primary outcome. We just, kind of kept follow-up of these patients.
So, very interesting study. I have two questions.
Sure.
firstly, once you randomize,
Sir.
what was the justification then for adjusting your analysis for melt sodium? Because randomization ensures the two groups are similar, then there is
Yes,
no
sir.
adjustment needed.
Yes, sir. Sir, actually, there was a numerical difference by 2 of MELD, which in multiple studies have been told as significant. Though we did not find it significant on our analysis, there have been multiple trial endpoints where 2 difference in MELD confers survival advantage. So we wanted to adjust for that.
So my suggestion would be not to adjust. Once you randomize,
Yes, sir.
some factors will be on this side, some will be on
Yes,
the
sir.
opposite, and that introduces
Yes, sir.
an
Point
error.
taken, sir.
The second issue is you had a difference in the final thing of only 5 milliequivalent per liter.
Yes, sir.
And there were 10 people who had a very rapid rise.
Yes, sir.
And obviously I don't have the exact details, so, but it seems that all the difference was because of those 10 people. And those 10 people were the cause of concern.
Yes, sir.
So, really speaking, you know, after this, do you think that risk of that very rapid rise is so high
Sir.
that you shouldn't still be using that?
So the thing was so the risk of rapid rise of sodium especially occurs in the setting where we restrict the fluid intake. So in our trial, we were careful not to restrict fluid intake. Once they were randomized into the tolvaptan arm, we did not restrict fluid so that dangerous hyponatremia did not occur. So which one, sir? No, we did not restrict in anybody, sir. Both, so that goes without saying, sir. We did not restrict in both groups.
Dr. Shiva Prasad from Visakhapatnam.
Yes, sir.
I just have a couple of queries. One is, you gave only for 7 days, and
Yes,
these
sir.
were patients with hyponatremia, but you followed them up for 24 weeks.
Yes, sir.
So none of them had recurrence of hyponatremia. Would that not be, what is
So-
the follow-up of that, of hyponatremia?
So we just looked at only whether the patient had survival at those points because we were planning more studies on this. Our primary outcome was only sodium improvement, and we were not powered for survival. It was just the follow-up
I'm
we
not asking
kept.
about survival. I'm
Yes,
talking
sir.
of recurrence of hyponatremia
No, we have not
in the
checked.
follow-up period.
No, we have not.
Just a question of checking the sodium levels and seeing how.
No, we
they
have
are
not.
doing.
We have not, sir.
Okay. The second point I would like to just mention, I mean, it's not obviously difficult. In setting of, tolvaptan is difficult to, I think, to give in a double-blind, randomized, placebo-controlled trial because ideally you would like to do dose titration. If a patient is having a response, you'll say, no, today I will stop the dose. Today I will ask the patient to skip or wait and see the urine output. Balance the dose according to the patient's response. There are patients who take just half tablet once in 2-3 days and they keep their sodium levels, at reasonable. So really speaking, to do a placebo-controlled trial, you may end up, creating more adverse events rather than trying to do the correct dose titration to what dose the patient would tolerate.
Sir, to answer your question, there was no dose titration in the study. We just used a uniform dose of 15 mg. So that was not a concern. And we had a similar tablet. And since we did not have dose titration, I think...
I agree with you.
Yeah.
7 days, it doesn't matter much. But for the use of tolvaptan, to use it as a placebo control is really difficult because ideally you'd like to do dose titration.
Yes, we would require. Thank you, sir. Thank you, Chair.